today I am going to be presenting on perioperative management of gender-affirming surgery. And Adu is my content advisor here, so big thanks to him. And we will go ahead and get started here. So, objectives for today's presentation. We want to understand the terminology and demographics of transgender and gender nonconforming individuals, describe different types of gender-affirming surgeries that are available here and elsewhere, as well as their associated complications. We're going to explore perioperative medical management strategies related to these surgeries, and finally apply all of this to a patient case, which we will get started with. This is where I'm going to ask you guys to participate a little bit. So meet the patient. This is KG, pronouns he, him, his. This is a 19-year-old student at the University of Wisconsin-Madison who presents to the clinic with the statement that he is transgender and he wants to start hormone therapy. KG's sex recorded at birth is female. He does not regularly see a physician, but seems overall healthy. Of note, he takes escitalopram 10 milligram once daily and has had no prior surgeries. So what are some considerations that we should make before proceeding? And you guys can just reply in the chat. Let's see as I try to pull that up here. Perfect. Okay, man, you guys are already going. Yeah, and we'll just go ahead. I won't read them out to you. It is D, all the above. There we go. All right, let's keep moving on to definitions here. Okay, now we're cooking. So we just want to define a couple terms before we go any further. The first is gender identity, having an internal sense of being male or female. I think it's important to note also identifying with both or neither. The second is gender expression. And so those are the ways that a person will communicate their gender identity to everyone else. These include the way they dress, hair, makeup, body language, voice, things like that. The next one is cisgender. That's an adjective for a person with their gender identity aligned with their recorded gender at birth. And we'll kind of get into that, but that would be a person who's born male and identifies as a male. And finally, this group of words, transgender, gender non-binary, gender non-conforming, are all ways to describe a person whose gender identity is not aligned with their recorded gender at birth. So let's keep going with some definitions and take this maybe one step further. Gender dysphoria. So dysphoria in and of itself is a state of unease or generalized dissatisfaction. So gender dysphoria is simply a mental health term referring to that discomfort felt by people due to that lack of alignment of gender identity and their sex recorded at birth. Gender-affirming hormone treatment, or GAHT, that's medical intervention for transgender people to align their appearance with their gender identity. And finally, we have gender-affirming hormone surgery, which is going to be the surgical intervention to do the same thing, align appearance with gender identity. So let's dive into gender identity itself. This is a pretty straightforward concept, I think, but can get a little tricky. I find it easier to start off with maybe the right side of this image here, starting with cisgender individuals. Again, they express a gender identity that matches their sex assigned at birth. So a cisgender woman was assigned female at birth, a cisgender man was assigned male at birth. Transgender individuals have a gender identity that does not match their sex at birth. So transgender woman was assigned male at birth, transgender man was assigned female at birth. Of note, gender-related terminology follows the person's gender identity. We also want to mention gender non-binary, which is a person who identifies as neither male nor female, and or they may identify with traits of both. Gender dysphoria, again, revisiting that. It's important to note here that, again, gender dysphoria is a mental health diagnosis that describes that discomfort felt by people when their gender identity does not align with their recorded sex at birth, but not all transgender people have dysphoria in and of itself. However, many insurance companies require that diagnosis of gender dysphoria for reimbursement of medical and surgical interventions. Despite the fact that being transgender is not a behavioral health concern, the codes for a transgender diagnosis are in the mental health section of ICD-9 and 10, but the plan for ICD-11 is to add the term gender incongruence as a new sexual health section and to remove gender dysphoria from that document. So just a little bit of background on that diagnosis in and of itself. For some prevalence here, the transgender population in the United States is 1.6 million people that are age 13 and up. And in our very own state of Wisconsin, about 0.34% of our population identifies as transgender, which is a little over 15,000 people. And specifically at UW Health, the main reason why I'm presenting today is because I met with Dr. Katie Gast, who is one of a very few group of physicians and surgeons who completed a fellowship in gender-affirming surgery and microsurgical breast reconstruction, and that was located in Belgium. So because of Katie, we have a very robust gender-affirming surgery program here to the point where we're a destination hospital. And we've had patients from all 50 states come to UW to receive care. We have a very large team of surgeons, physicians, nurses, nurse navigators, social workers, counselors, schedulers, of course. And we also partner with the head of DEI at UW Health in order to take care of this population. And we serve hundreds of patients annually. So there's a little bit of background on what we're going to be talking about today. And now let's get into the types of gender-affirming surgeries that are available. So there are some overarching categories when thinking about the various types of gender-affirming surgeries offered. And this is usually including some kind of facial modification, whether it's feminization or masculinization. And then there's top surgery, which can go both ways, trans-feminine or trans-masculine, and then bottom surgery, of course. So let's define some specific surgeries that we offer here at UW, starting with trans-masculine or female to male, or FTM, which is how I'm going to notate that throughout the rest of this presentation. So these, you can tell with the red box, are some different procedures that a trans-masculine patient might receive. So a mastectomy being the top, removal of mammary fat and tissue, a hysterectomy, removal of the uterus, oophorectomy, removal of ovaries, metoidioplasty, creation of a phallus, phalloplasty is a similar thing, using specific tissue graft. And then there's some more, kind of as we follow here. Each of these come with specific complications, mainly revolving around scar tissue formation, but it can become a hematological issue with clotting, thickening of vascular walls, and then you can get into things like urinary retention, fistula formation, even skin necrosis and infection. So complications can range and be very serious. Now we're going to look at trans-feminine surgeries, so that is male to female. And again, I'm going to notate that with an MTF throughout the remainder of this presentation. So surgeries are listed there under procedures: breast augmentation, which includes implantation, rhinoplasty, which is usually some kind of nose reshaping. There's a number of them here that range from top and bottom and facial surgeries. Some of those bottom surgeries include orchiectomy, removal of the testes, vaginoplasty, which is the creation of a vagina, clitoris, labia, and then vulvoplasty, which is a creation of a vulva, and so on and so forth. And again, these come with their own complications. Many of them are similar: scar tissue formation, vascular thickening, bleeding, infection, things like that. So let's take a moment to pause here and revisit our patient. KG has returned to the clinic a year later. He's been taking hormonal therapy in the form of testosterone injections and is now interested in surgical transition methods. So this question is asking about those specific surgeries. Which of the following would be of interest to KG? A vaginoplasty, vulvoplasty, mastectomy, or orchiectomy? Yep, I'm seeing some correct answers in the chat. That answer is C, mastectomy. If you forget who KG is, we're using proper pronouns for him: he, him, and his. He identifies as a transgender man who was born female. So of the options given, only one really aligns with that patient's goals for a transmasculine transition, which is the mastectomy. Oh, I don't believe that is removal of the uterus. And I'll make sure of that one after this. So now let's get into more of the medical management side. Today I'm going to focus on the impacts that we as pharmacists can make on this patient population, especially when they're kind of at their most vulnerable during that perioperative stage of their transition. So we're going to be going over a lot of different things as they relate to their medicine. But the first thing I wanted to cover is kind of revisiting that idea of always using the patient's self-identified name and pronouns and how we can find that in an Epic or HealthLink. So this is a screenshot that I pulled from the playground. So this is, of course, falsified patient information. But this patient, as you can see, we have that yellow box that describes her gender or her sex being female, and that's always a key indication that you can look there to see if there's more information. So if you were to hover, you can also see their pronouns. Hers or she, her and hers. She also is okay with using they, them, and theirs. And again, once you hover, you can see that her gender identity is a transgender female with a sex assigned at birth of male. So all things to take into consideration whenever you are treating these patients, especially if it's, you know, on a surgical floor where they are, it's more of a likelihood that you might run into this kind of patient population here. Obtaining an accurate medication history is obviously something that we strive for in every patient. But as part of that preoperative assessment, it's critical to obtain that patient's treatment regimen and be aware of the associated side effects and pharmacological interactions. So medications being the first thing, centering around that hormone therapy, which we're going to get into. The second, PMH, all those things like mental health, infectious disease history, VTE history are going to be important for their stay. Any kind of drug reactions that you might be seeing, especially from that hormone therapy, if they're taking it, their surgical history, and finally their goals being that individual stay or their goals of their transition. So some perioperative assessments that we make at UW Health that are kind of, you know, specific to this patient population, starting with mental health. Many gender-affirming surgeries require preoperative psychological assessments from mental health clinicians that enumerate any kind of psychiatric diagnoses and evaluate a patient's eligibility for surgery and confirm their capacity for informed consent. The next one is infectious disease, centered around sexually transmitted infections is something we always look at. Cardiac risk, assessment of perioperative, major adverse clinical events, and the determination for the needs of, you know, modification for their management. as well as identifying any kind of cardiovascular conditions or risk factors that require long-term management. Moving on to that pulmonary risk. So that kind of risk assessment is to minimize post-op pulmonary complications during that recovery phase. Common things are atelectasis, infection especially, respiratory failure. If they have chronic lung disease, we don't want any exacerbation of that. Pulmonary edema, so on and so forth. And finally, bariatric status. So based on surgical techniques and surgeon preference, BMI can be a limiting factor for gender-affirming surgeries. Being an elevated BMI can cause the patient to be at an increased risk for cardiac and pulmonary and endocrine risk there. So these are some of the assessments that we make before a patient ever steps into a surgical floor. So moving on to hormone therapy management. Gender-affirming hormone therapy, or GAHT, is what I'm going to refer to it in this presentation. Is obviously very common in this population with several types and formulations of hormone therapy that are available. And of note, we do have the concern for VT, which we're going to get into. However, there's really not a consensus approach to perioperative hormone management as it relates to VTE. Some areas practice by holding hormone therapy 2 to 4 weeks before surgery. Some do not hold at all. And there hasn't been too much of a benefit that's actually been detected, but we'll kind of cover that a little bit more in depth. So that therapy, the therapy options that are out there, types of transfeminine therapy that's commonly used for transgender women include oral estradiol, transdermal estradiol, and parenteral in the form of estradiol, valerate, or sapien 8. They're often combined with anti-androgen therapy, such as spironolactone, cipterone, acetate, finasteride, dutasteride, things like that, to produce that desired physical change, such as breast growth, fat distribution, and decreased facial and body hair. A few of them I want to focus on. Spironolactone is, of course, a potent mineral corticoid receptor antagonist that blocks the effects of aldosterone and can have effects such as on hypertension and a diuretic effect, including hyperkalemia as well. Ciproterone acetate is actually not available in the U.S., but we may see that every once in a while for patients who are Canadian. Finally, gonadotropin-releasing hormone agonists, such as leuprolide, suppress testosterone levels, but are generally considered as more of a second-line therapy, owing to basically their high cost. Moving on to the transmasculine hormone therapies that are available, and really it's just testosterone. So evidence kind of suggests that there's no need to discontinue testosterone treatment routinely in transgender men before or during a scheduled surgery. Testosterone can be aromatized to estradiol, which we're all aware of, which could increase that clotting risk, right? However, there have been many systematic reviews of this association with no evidence of needing to hold therapy. However, it is not lost on any of us that this is a small patient population, and we are, lacking evidence, of course, in these patients. So practice may differ for testosterone as it relates to perioperative management. I did also want to touch on testosterone is available parenterally in those same forms, as well as topically in a gel or a patch. Now, changes that we can see from each of these hormone therapies, things just to be aware of. From estrogen, it can increase red blood cell count, hemoglobin, hematocrit, creatinine, of course, and triglycerides. It can decrease, though, calcium, albumin, and ALK phosphate. And as it relates to testosterone, more of these increases, including AST and ALT, and it can actually reduce HDL, which, is a similar profile to estrogen, but slightly different, things to be aware of. And then drug interactions, of course. These are mainly centered around estrogen, which has several drug interactions documented. Estrogen can affect neuromuscular blockade by decreasing pseudocholinesterase activity and prolonging muscle paralysis from succinyl choline. Sugamidex is also one. It's been shown to bind to estrogen and thereby decreasing its effects in that postoperative period. And finally, estrogen in doses that are associated with in vitro fertilization can cause the decrease in things like albumin, as well as bind to bupivacaine. So careful attention should be paid to these significant interactions between some of these more psychoactive, as well as antiretroviral medications as it relates to estrogen. So let's get into how we manage GAHT here at UW. In the pre-op phase, for all trans feminine patients, estrogen is stopped prior to surgery due to that VTE risk. However, if patients were on spironolactone, that is normally continued. In the post-op area, any kind of anti-testosterone drugs like spironolactone are held postoperatively, since patients undergo usually an orchiectomy and no longer produce testosterone. Spironolactone may, however, be resumed post-op if it's being used for other indications. Checking with the team to confirm those other indications if the patient was on spironolactone preoperatively will be important. Other than that, estrogens are held through hospitalization due to that increased risk of VTE, of course, but they're usually resumed at the time of discharge unless the VTE risk is present and outweighs any kind of benefit. For patients undergoing a transmasculine transition, testosterone, like I said, is continued through the perioperative period since the risk of VTE is not as high compared to estrogen. So let's take a minute, revisit the patient. KG is receiving a double mastectomy. So what are some considerations to make regarding his testosterone therapy specifically? That A, testosterone should be held perioperatively due to the interaction with Sugamidex. B, testosterone should be continued perioperatively. C, testosterone should be switched to an oral formulation perioperatively. Or D, testosterone will likely decrease AST and ALT. Not seeing any answers in the chat. Okay. Oh, yep. Beautiful. I'm seeing some Bs, which is the correct answer. Just to kind of explain these a little bit, A is really more around estrogen, and it's not necessarily stopped because of that Sugamidex reaction, but it is or interaction rather, but it is something to note. B is correct. C, we do not have an oral formulation for testosterone, and D, testosterone will likely increase AST and ALT, not decrease. So good job. Let's move on from hormone therapy to the mental health side of things. So as I kind of touched on already, transgender patients continue to face significant levels of discrimination and stigma, even physical violence throughout society. That may contribute to increased psychiatric and physiologic sequelae. Data suggests that there's higher incidence of mood and anxiety disorders than compared with cisgender folks, with suicide rates remaining one of the leading cause of death of transgender people. Pharmacologic therapies and potential psychoactive drug interactions should, of course, be evaluated by the pharmacist, and careful consideration should be given to patients on things like TCAs and mood stabilizers like lithium, as well as SSRIs. But due to that increased prevalence of mental health diagnoses among this population, antidepressants and antipsychotics should be resumed whenever clinically possible. Of course, compounding the high burden of psychiatric disease among transgender populations are high rates of alcohol, marijuana, cocaine, things like that. And intoxication and chronic substance use disorder are challenges for any kind of surgery that might be occurring, so consideration should be made there as well. Moving on to infectious disease management. So testing protocol does not differ from cisgender patients. Patients should be tested for HIV, hepatitis B and C, and syphilis, especially based on individual risk factors. Patients with HIV or hepatitis should be on some kind of antiretroviral therapy regimen and have undetectable loads excuse me, prior to surgery. HIV patients specifically should have a CD4 count above 300 before starting any kind of surgical procedure. And I just wanted to highlight HIV as we know it now for a moment. Just to give you some numbers, the U.S. population of people living with HIV are 1.2 million. We have new cases, about 35,000 in 2019. However, 2% of those were transgender. And within that transgender population specifically, and trans women, if we want to highlight that, they're 49 times of a higher risk of contracting HIV than cisgender people. And the prevalence, based on a study done by the Human Rights Campaign, where they interviewed about 2,000 transgender women in 7 major cities across the U.S., 42% of women, of transgender women, had HIV actively. So these are things that we always need to take into consideration when treating our patients. So moving kind of back to just the perioperative antibiotic management at UW Health specifically. All patients receive perioperative antibiotics for surgical prophylaxis, and typically cefazolin is used based on our UW Health surgical prophylaxis guidelines. Male to female patients specifically, or trans feminine patients undergoing vaginoplasty, have antibiotics are started post-op and continued while any kind of vaginal packing is in place, which is usually about 5 days to prevent any kind of urinary infections. Packing is removed prior to discharge, so patients will obviously not need the antibiotics at that point. Bactrim is preferred. If Bactrim can't be used due to allergies or intolerance, other alternatives include Augmentin, cefepime, ceftriaxone, things like that. Target organisms are inclusive of gram-positive and gram-negative. We used to have coverage for Pseudomonas, but that is no longer needed at this point. Looking at transmasculine patients, no further antibiotics are needed for past the perioperative phase. Moving on from infection risk. So let's move into more of the VTE and bleeding risk reduction. Of particular concern is the risk of VTE in the context of both longitudinal and acute hormone therapy. Formulation of hormone therapy, including the dose and the route and the duration, of course, can affect a person's VTE risk. But there are no existing risk scores for VTE that consider hormone therapy as a possible risk. In patients with multiple VTE risk factors, such as obesity and tobacco use, or a history or a family history, prophylactic anticoagulation should be considered. And quantifying that risk in this population obviously can be very difficult. There are many factors that are of interest here that I kind of just mentioned and should be taken into consideration as it relates to bleeding. Tranexamic acid carries a black box warning cautioning against the use in patients who are receiving estrogen therapy as a hormonal contraceptive. This risk primarily applies to patients who are receiving higher doses of estrogen and had additional risk factors for VTE. However, the risk of using antifibrinolytic therapy in the transgender population is not well known. So basically, you need an individualized approach for each of your patients. Now, getting into the way that we manage this at UW Health, all patients who are undergoing gender-affirming surgery get some kind of VTE prophylaxis. where enoxaparin or low molecular weight heparin is preferred. I forgot to mention, all patients get VT prophylaxis unless it is contraindicated. Just need to state that. So again, low molecular weight heparin is preferred starting on post-op day 1. And for patients with limited ambulation at the time of discharge, it can be continued through that first follow-up appointment in clinic. Patients with a history of VT may also receive heparin or some kind of VT prophylaxis at that time of discharge to continue. Moving on to the bleed risk. So again, we're talking about vaginoplasty patients, trans feminine patients. They all receive TXA infusion. TXA is initiated at 1 mg per kg per hour and continued until the morning of post-op day 1. So these infusions are limited post-vaginoplasty with no exclusions in the population, and renal dosing should apply, of course, and we can always refer to our guidelines and lexicon for that. Blood pressure management, I thought, was also pertinent in this area, as we want to minimize the risk of bleeding at surgical sites. So systolic blood pressure is usually maintained below 135 using clonidine, so 0.1 to 0.2 mgs every 8 hours, just kind of is needed to keep that systolic blood pressure below that limit. Moving on to some other maybe more acute issues, pain management at UW Health. Dr. Gast has a strong sense of the issues of addiction and things that occur in this population, and so we minimize opioids as much as we can. Rarely are patients discharged with an opioid prescription or a bowel regimen for that matter. If we do need an opioid, morphine is kind of that first choice. And we always, of course, like to push the multimodal approach, opting for Tylenol, preferring that. Also, NSAIDs could be used, all of which starting at post-op day 1. Bowel management is another issue, of course. So preoperatively, according to Dr. Gast, we do Miralax and Gatorade. So, good old concoction there prior to our vaginoplasty patients, or those surgeries rather. And then post-op, we have a couple different tools to use to prevent stools from contaminating any kind of flaps or surgical incisions. Patients who have recently undergone gender transition surgery will get stool softeners and laxatives held, though, at least through post-op day 2 or longer, depending on provider preference. Loperamide can be used as needed. It could often be scheduled within the first 3 days of surgery and maybe changed to PRN later in that course of hospitalization. And finally, Docusate may be prescribed starting on post-op day 3 to prevent any kind of straining, which we don't want when we have those surgical incisions that are healing in that area. There are a couple different factors that we need to consider when assessing risk, dosing medications in this population that take sex into consideration, right? So the first of these is renal clearance. And we can see on this sort of like stepwise approach, some of these, like especially this first 3, inulin clearance and serum cystatin C and 24-hour urine collection, are perhaps accurate of real EGFR, but we don't normally use them because they're expensive, inconvenient, so on and so forth. So what we use is at the top of the little staircase there, and that's estimating creatinine clearance using Cockcroft-Gault. Of course, this equation uses a number of things like body weight and sex to form that calculation, and there hasn't been a lot of data of course, in this population to determine what we exactly should be doing. And so there's really not a national or a widely accepted standard for this. But one good article was published in AJHP regarding this exact situation in transgender patients. They opted to use ideal body weight with the identified gender if the patient was taking hormonal therapy for at least 6 months. Their argument was that the patient at that point is similar enough to the identified gender to where we can now calculate it the way that you would if that person had that sex assigned at birth. Another calculation, if you have it, is the CHA2DS2-VASc score, right? So estimating that stroke risk in patients with AFib affected by age. I think that's, I meant to put by sex, without any literature in the transgender population. And when I say there is no literature, there's really none that I could find. So what we recommend is, first of all, figuring out if the outcome is affected by sex, by that additional +1, if the person is female at birth or whatnot. If the outcome does not change, then we can worry about it less. If it does, then we need to consider that risk versus benefit kind of on the individual level for the patient. So we really don't have a great answer there. And that just kind of goes to show you of all of the information and all the studies that are needed in this specific population that aren't there. We obviously have a lot of room to grow for our transgender population. And finally, we are going to revisit KG one more time. He's now coming back for a total hysterectomy. Which of the following are accurate principles of perioperative medical management based on what we just learned? A, restarting any kind of antidepressants as soon as medically able. B, maintaining systolic blood pressure less than 135 using purine clonidine. C, starting low molecular weight heparin on post-op day 1 for VT prophylaxis unless it's contraindicated. And D, all the above. Good job. I'm seeing some Ds in the chat. You guys are right about that. One more thing to get into before I finish is this idea of cultural humility. I would be remiss without putting this out there kind of at the end as a takeaway for all of us. Cultural humility is an iterative and circular approach to patient care that, number one, promotes lifelong self-evaluation and self-critique. 2, dismantling that power imbalance between the care team and the care recipient. And 3, fostering mutually beneficial partnerships with those communities being served. In this case, it's our transgender community. So cultural humility invites particular attributes of openness and self-awareness, removing your ego, being supportive, self-reflection, all of these things. And the shift toward cultural humility is the premise for dismantling that marginalized health system and rehumanizing the care experience for transgender patients. A good way that we can start to do this is by learning your own implicit biases so that you can reflect on how they might translate into your clinical practice and then strategically interrupt the way that that's happening. So I'll be sending out my slides after this presentation containing a link. If you click on where it says implicit bias test, there's a link there to an online test by Harvard University. If you've never taken one, I highly encourage you to do so as a way to understand your own biases. You might be surprised, you might not, but it's always something good to continually self-assess and know about yourself. So with that, I want to thank everyone for joining. A big thank you for Adu for helping me put these slides together and have a thoughtful presentation. I want to thank Katie Gast for her assistance in the production of this presentation and some really good guidelines as to how they operate and how they see pharmacists that can assist them as best as possible. And with that, I will now take any questions you might have.